Good morning, ladies and gentlemen, distinguished speakers and delegates. Welcome to Day 2 of the Sri Lanka Surgical Congress. It is our honor to guide you through today's sessions, which promise to bring forth valuable insights and advancements in surgical practice.
Kicking off Day 2 here at the Peacock Hall, we have a series of symposia covering a diverse array of surgical topics. These sessions are sure to be both insightful and enriching for all attendees.
Let's begin our day with Symposium 13, titled Surgical Management of Soft Tissue Infections of Limbs. This symposium will focus on the latest developments in diagnosing, managing, and surgically treating soft tissue infections of the limbs, which can often present with significant challenges in both acute and chronic settings.
Without further ado, to chair this session, I cordially invite Dr. Duminda Ariyaratne, Consultant General Surgeon, and Dr. Duminda Disanayake, Consultant General Surgeon. Over to you, sirs.
Good morning, sir, and ladies and gentlemen. Welcome to the Symposium 13 on the third day, or rather this is the second day of the annual Congress of the College of Surgeons of Sri Lanka. This session is chaired by two Dumindas, and the resource persons are Dr. Kosala Somaratne, who is the Consultant General Surgeon of Base Hospital, Teldenia, Dr. Mihira Bandara, again a Consultant General Surgeon attached to Colombo South Teaching Hospital. Dr. Mahen Kothalawala, Consultant Microbiologist of National Hospital of Sri Lanka, and Dr. Kosala Karunadasa, Consultant Plastic and Reconstructive Surgeon of North Colombo Teaching Hospital. Without much further ado, let me invite Dr. Kosala Somaratne to commence his presentation on management of necrotizing fasciitis and cellulitis in extremities. Over to you, Kosala.
Working? I want, ladies and gentlemen, with the permission of chairs, let me take you through this necrotizing fasciitis, the compartment syndrome of the skin. Okay, let's start with anatomy. This is a schematic diagram of the skin, and you get the epidermis and the dermis here, and then you get the subcutaneous fatty and areolar tissues, and then you get the deep fascia and the muscles and bone. Now I want your concentration here. You see how the blood supply works for the skin. Through this tissue of fat and areolar tissue, the blood vessel traverses, and take note of this, that it is not ramifying. The blood supply to this area is poor. And as surgeons, you know, when you cut the skin does bleed, but beneath that, there's not much of bleeding till you hit the muscles. And this is important to understand the pathology in necrotizing fasciitis and cellulitis. If you go to the histology, it's like this. This is the area I'm referring to, the area of fat and areolar tissues where these blood vessels do traverse, the logistics do travel to the skin. Okay, and when it is cellulitis, we are talking about this part, the skin and the dermis. But when it is necrotizing fasciitis, we are talking about this layer, the fatty areolar tissue layer, which is poorly perfused. Okay, let's change the topic. Get back to history. In 19th century, Napoleon Bonaparte, as it was called, the Grand Army of Napoleon Bonaparte, attacked Russia in 1812. And the French, as the French call it, Compagnie de Russie. At that time, Napoleon's army was invincible, the most powerful army on earth. And there was a big battle called Battle of Borodino. French won it. It was here, just in the outskirts of Moscow. But after that, for some unknown reason, this grand army just crumpled. And then there was the catastrophic return of the Napoleon's army back to the old Europe. And there's a similarity between what we're talking about and what happened here. We are talking about this part, and this is where the Russians did attack, the logistics. And the army just crumpled. And they repeated this feat again after a century and a quarter against the army of Hitler from 41 to 45. And in a sense, what Mr. Donald Trump says about the current war in Ukraine, that Russia is invincible, probably may be correct going back to the history. So anyway, back to our topic. Okay, so that is about the anatomy of necrotizing fasciitis. What about the physiology? If we go back to our first year in medical school, we know the Starling's forces, and the tissue pressure in the subcutaneous tissue ranges between -2 to +6 millimeters of mercury. But in infections, this can rise up to say about 20 millimeters of mercury. Okay, turn back to the Starling's forces. You know, at the arterial end of the capillary, take note of this, the net pressure outwards is 10 millimeters of mercury, and this calculation is done supposing that the tissue pressure is 0. What happens when the tissue pressure goes to 20? Even at the arterial end of the capillary, there's a net pressure inside. So virtually, literally nothing comes out. No food, no oxygen. So the tissue is just, there's no logistics, just crumples. Okay, so this is what happens. This is the histology, and you see the blood vessels here, all thrombosed. Nothing goes to the skin, and this result is the skin necrosis. There's no immunity, the immune cells are not working, so this is the result, the huge growth of bacteria in this subcutaneous tissue. And in general, it is the gram-positive cocci, streptococci or staphylococci, which causes necrotizing fasciitis in general terms. And there's an idiom in Sinhala, it's called Paluge Valambidina, and in English you call it, you kick when somebody is down, and that is exactly what's happening in this tissue. So the microbes have a free go there. Right, okay, how is the presentation? If it presents early, it is just cellulitis, but you should take note of this. It's unduly painful. Particularly the patient complains of a burning pain, and again it's very painful to touch, very painful to touch. Remember our well-known compartment syndrome, the same thing happens here. This again is a compartment syndrome, and it is the ischemia of the nerves, cutaneous nerves, that gives this burning undue pain. When it is late, of course, it's obvious. There's skin necrosis, and there's bullae, and the patient is septic in general. So this is the usual picture we had. A patient comes with large areas of necrosis, you take to the theater, you do a radical debridement, and you get this large areas of tissue necrosis, and you have to do repeated wound toilets, and let it granulated, do skin grafts, some sort of reconstruction, and long stays in the hospital. Now, this was the story till we got hold of this pathophysiology, but it is not anymore the case. Understanding the pathophysiology was a game changer. Now, this patient presented to our unit last Wednesday at 4 p.m. His leg was like this, and the next day morning the leg was like this. So what happened? If you have a quick look, you can see multitude of stabs, through and through stabs placed in the skin. We took this patient to theatre at 6 p.m., just 2 hours after the admission, and did this multiple stabbing, aggressive antibiotic therapy, and we did not have further necrosis. We could put a stop to the process. Necfas is bound to produce bad results until you take it as a real surgical emergency. go for aggressive broad-spectrum antibiotics, and this is our policy. Mahen might further elucidate in this. We give IV meropenem 1 gram stat and an infusion of further 1 gram over 12 hours and another 1 gram of another next 12 hours. So within first 24 hours, the patient gets 3 grams of meropenem as an infusion. And this we do not check the renal functions importantly, because this kidney is stunted in these patients. Unless it is pretty obvious that this patient is CKD, we don't go for renal adjustments. We do the adjustments after the first 24 hours. Then to the operating theatre as an emergency, and importantly there's no fasting completion. Immediately take to the theatre, do the stabbing, get the physiology correct. It's like damage control. You get the compartment syndromes released. The same thing you do with the compartment syndrome of lower limb or upper limb. Same stuff. Further management, close monitoring, resuscitation, good urine output, tight blood sugar control. Don't play around with oral hypoglycemics. Get the patient on insulin if the blood sugar is fluctuating. Good nutrition, mobilize, sunlight, give a shower before wound dressing. And in our unit policies, dry dressings twice daily with povidone iodine painting. And it is quite easy for the first couple of days. And further journeys to the OR as and when necessary. And once we get a good hold of sepsis, we might go for a resection of the necrotic parts of skin and to be a bit different to the traditional thought of necrotizing fasciitis. We don't go for radical debridement then and there unless there is pus underneath this necrotic skin, because in our experience even the necrotic skin, once we get hold of the infection, it gives a good cover for some granulation to come. We keep a close eye on this patient, and if it is becoming septic infection underneath, then we will remove the skin, not otherwise. In summary, treat neck rash with the same urgency you treat any other compartment syndrome. Release the compartment pressure, aggressive antibiotics and resuscitation. Bom stuti.
Thanks, Kosala. We'll leave questions for the end of the symposium. I would like to invite Dr. Mihira Bandara, Consultant General Surgeon, Colombo South Teaching Hospital, to discuss about the pitfalls in managing diabetic foot infection.
Right. So, pitfalls in managing diabetic foot infections. Diabetic foot infections is a very common problem we manage in our general surgical units. I base my presentations on my experience and observation from my training days and practice as a surgeon for over last 10 years. So, first of all, introduction, 20% of the diabetic related hospital admissions are due to diabetic foot infections. 85% of the diabetic related amputations are preceded by ulcer, which often give rise to infection. Mortality is significantly higher for foot infection and diabetes than without infection. So these statistics highlight the importance of the topic diabetic foot infection. If we were to achieve very good results with the diabetic foot infection management, we should have a very good understanding about the pathophysiology. As you all know, long-standing diabetics leads to peripheral neuropathy, peripheral arterial disease, impaired immune response. And neuropathy leads to leg ulcer due to loss of sensation. These ulcers, together with impaired circulation, results in delayed wound healing and increased risk of infection. This infection flourish in the background of microangiopathy and the impaired immune response, and is spreading along the tissue planes and tendon sheath, sometimes producing abscesses and producing necrosis, and sometimes severe sepsis. So, how do we diagnose? It is clinical diagnosis, easy. Most patients will present with the swelling, and some may have pain, redness, inflammatory signs. There may be smell, discharge, and we also need to focus on the history of previous food complication, recent history of prick injury or fungal infection, duration of the diabetics, and the treatment given so far and by whom patient was treated, because all these factors are important in decision making. And examination should focus to find out any signs of peripheral arterial disease and neuropathy, and particularly not only inspection, very good palpation to detect any hidden collection around the edges of wound is very, very important. So how do we investigate? So these investigations, certain blood investigation, microbiological investigation and radiological investigation will help us to understand the severity of the infection and causative organism in all, and to institute antibiotic, and any comorbidities that will delay the wound healing, and any possibility of the complications such as osteomyelitis and peripheral arterial disease complications. Treatment, that is the most important part here. So I have recognized 4 main pillars. First, the appropriate antibiotics. The broad spectrum intravenous antibiotics usually started first, then we give the targeted therapy depending on the culture ABST results. And surgical intervention should be done as urgent basis, and it may be adequate drainage or adequate debridement, or sometimes to the amputation of toes. Sometimes even from the beginning we might have to resort to the BK amputation for the delayed severe sepsis patients. And we should give adequate attention to the glycemic control and proper wound management, including wound dressing and the offloading of neuropathic and the deformed foods, and improving circulation if there is a peripheral arterial disease, and a vascular surgical consultation referral, and improving nutrition. Since this diabetic wound infection cause significant morbidity and the loss of working hours and significant impact to the family life and the country, so it is more appropriate to look at why we get poor results, poor outcome in our society. So I have recognized these areas: the late recognition and late referral to the specialist, and mismanagement at surgical units, and certain follow-up issues. Late detection. The patient is expected to inspect their feet daily to detect any injury, small injury or the inflammatory signs or discharge ulcer. But some patients may have a difficulty to do by themselves. They may need help of family member because of they have a poor vision or the joint problems. Elderly living alone may have a difficulty to do the daily infection sometimes. Neuropathy and not wearing proper footwear, fungal infection, untreated callus and corns usually leads to ulceration and infection. Late referral to the specialist. In our society, most patients, when they have a small problem or this foot infection, ulcer, they usually go to the general practitioner or family physician. There are some family physicians, general practitioners who has very good understanding and the skill to manage this, but majority do not seem to have adequate skill and knowledge to manage. They usually rely on antibiotics. They go on changing from one antibiotic to the other, and they sometimes try debridement drainage procedures. They are usually inadequate. And there is a wrong practice of managing prick injuries among them. I will deal with it later. Therefore, debridement and initiating intravenous antibiotics often delayed in many patients. With regard to the prick injury, that is the most important cause and the common cause for diabetic foot complication, for diabetic foot infection in our society. So they usually got the general practitioners, what they do is they superficially clean with the saline and apply some providing iodine and put a dressing and give some oral antibiotics and review maybe 2-3 days time. So it is like the prick injury is like inoculating in a culture plate, because with the prick the bugs are inoculated deep in the tissues where there is not much vascularity and the poor immune response, so infection flies quickly. So what is the proper management? So the tract should be explored under anesthesia and it should be thoroughly irrigated, and we should leave adequate room to drain if there is an infection, and we should make sure the close follow-up and review, and depending on the patient condition, comorbid condition, diabetic control and the previous foot complications or the immune status, is better sometimes giving a additional few doses of even intravenous antibiotic at the onset. So this is a patient with a prick injury, has gone to general practitioner initially, and he has been doing the continuing oral antibiotic and certain the dressing as I mentioned. So patient got necrosed 4 foot, and at that time he asked to go and consult a surgeon to debride this necrosed tissue. Pitfalls in hospital practice. There are still some mismanagement or pitfalls happening in surgical units. There will be delay in the wound debridement due to the availability of the theatre time, or delay decision to go for a debridement. When a patient admitted to surgical unit, they usually have a fear of losing their toes or leg that is in the society. So, but this fear is further aggravated by the fact that if the patient is taken to the theatre every other day or every second day for debridement, and they go on doing debridement 5-6 times without getting controlled. So at that time, patient, him and the family, they get worried and they decide to go against Lama and seek another hospital or another surgeon. I have been able to attend some of that kind of patients for whom amputation has been recommended by the other units. But I could manage, I could save the legs without amputation, merely adhering to the adequate debridement and the first go, and starting very good trustable antibiotics in the beginning, and proper attention to the glycemic control. So it is very clear to me, sometimes debridement is not happening properly. So usually these procedures are performed in surgical units by the maybe residents or maybe SHOs. But if this is happening, the surgeons in charge has a responsibility to supervise their research efficiency, their training, because in my experience, you don't need 5-6 times debridement to get infection under control. Maybe maximum 2 or 3. Most cases in the first go you can get the adequate sharp debridement to get the control. And sometimes the patient is discharged early to community or the peripheral hospital for the further care without proper plan and without considering the family issues. So however much you put an effort to get the control of infection initially, they again go to the infection quickly. So this is another patient. Patient had been managed in a surgical unit and discharged, and patient again went to the community GP and they started treating. Several days later again came to me with severe purulent discharge and necrosis. So therefore we need to make sure very good discharge plan. We have to make sure the glycemic control after discharge, who is going to take up giving the insulin or the monitoring at the glycemic control at home, and who is going to give the wound dressing, is that person the trained person or using sterile precautions, sterile methods, and surgical team has a responsibility to review them depending on the patients, maybe once a week or twice a week. By that way we can ensure the patient is in the correct pathway, is not deteriorating, and patient should be instructed when to review them urgently, then they can be asked to even come to the wards. Whoever in the team, surgical team, can review and get the senior opinion, act immediately. So in summary, in order to avoid pitfalls and improve the outcome after diabetic foot infection, patient education on daily inspection of feet to early detection, and urgent surgical intervention and adequate debridement by a trained person, education and training of general practitioners, education and training of the supervision of surgical teams, proper management of prick injuries, and a rational approach to antibiotics, and good glycemic control and proper follow-up care plan. Thank you.
Thank you, Mihira. Thank you, Mihira, for interesting lecture. Next topic would be microbiological basis of managing soft tissue infections of extremities. I cordially invite Dr. Mahen Kothalawala, consultant microbiologist, National Hospital for the podium. Thank you.
Thank you very much for inviting me, ladies and gentlemen. Today is World Sepsis Day, and skin and soft tissue infection is one of the major killers due to sepsis. So my topic is microbiological basis of management of soft tissue infection of the extremities. So I will give you the conceptual framework of management of skin and soft tissue infection in relation when you look at from the bacterial side. So infections are said to be two-dimensional diseases. So that means they have a microbiological dimension as well as clinical dimension, very simple. So these clinical and microbiological dimensions are very well interconnected and you can't separate it out. So you can't make a patient's microbiological management or surgical management. Both has to be done at the same time concurrently. So being infections, soft tissue infections have both dimensions. So we have to keep that in mind. So the microbiological dimension is there and the surgical and clinical dimension is there. So the clinical dimension generally presents as a continuum. It's as a spectrum, not a single entity. So it varies from mild localized infection to severe life-threatening infection. So here is the clinical dimension that I am going to give you. So it has two ends. One is a mild end and the other one is the severe life-threatening end. So when you compare these ends, these are just like ahasata polowagi. So they are different. So the mild end is where the patient not ill. In severe end, patients are septic with lot of necrosis who needs admission and sometimes they can die. So if you analyze the number of patients who died from sepsis, majority of them having skin and soft tissue infection, necrotizing fasciitis and myonecrosis. So soft tissue clinical continuum can be further categorized into two groups based on presence of necrosis. So if necrosis is there, you call it necrotic skin and soft tissue infection, and if there is no necrosis, you call it non-necrotic skin and soft tissue infection. So the prompt surgical intervention, that is source control, is essential when you suspect necrosis. Not only antibiotics, you have to have as Kosala mentioned, you have to have early aggressive surgical therapy plus early aggressive antimicrobial therapy. So now let's look at the microbial dimension of skin and soft tissue infection. So most common organisms which causing skin and soft tissue infection are Staphylococcus aureus and Streptococcus pyogenes. When you take skin and soft tissue infection, that is basically a gram-positive disease. So therefore, you need more gram-positive coverage than gram-negative coverage. So although they are most prevalent organisms causing skin and soft tissue, you can't forget the role played by gram-negatives, because gram-negatives and gram-positives, they act synergistically. So they help each other to bring the pathology in. So therefore, severe end of skin and soft tissue infection, so you might have to think of covering much broader spectrum than covering only the gram-positives. Effective treatment necessitate the addressing of full potential causative agents. So how are we going to use our knowledge in microbiology, the general microbiology, third year microbiology, in management of soft tissue infection? So that can be achieved with three methods. So that's it. Effective management of soft tissue infection hinges on three pillars. What are these three pillars? Establishment of accurate diagnosis. Second one, selection of appropriate treatment regime. Third one, to prevention of complication. So how are we going to achieve the diagnosis? The diagnosis is two parts. The clinical diagnosis, where you can come into action, and etiological diagnosis, where you have to go ahead with do some sort of a lab work. But unfortunately, in skin and soft tissue infection, pinpointing the specific pathogen responsible for skin and soft tissue infection is very difficult. Sometimes you might get a positive result, but you have to always think that, is this the pathogen, or can this be a contaminant or a colonizer? If you just try to treat the microbiology report, sometimes you might miss the bug. So selection of appropriate treatment. So the treatment has two arms. One is antibiotics, the other one is source control. So you can give antibiotics plus or minus source control. So the antibiotics are either empiric therapy or targeted therapy. Empiric therapy, you give it on the clinical grounds, best case basis. And once you get a microbiology or lab workout, you consider giving targeted therapy. But again, you have to keep that in mind. The culture that you are getting may not be the pathogen that causing the disease. So you have to always keep that in mind. Determining the optimum timing, route of administration, and what the initial antibiotic you are going to give is an imposing hurdle. Surviving Sepsis campaign, as I mentioned, with today's World Sepsis Day. So the leading sepsis management campaign in the world is Surviving Sepsis campaign. So they recommend giving antibiotics within 1 hour if the patient is having shock, septic shock. If the patient is having sepsis, so it can be delayed up to 3 hours. If there is no sepsis, you can do your lab workup and then decide on the treatment. Timely decisions of antibiotics and source control exert a profound influence on determining the trajectory of the patient's clinical condition. So this is complications. My colleagues discuss about that. I am not going to talk on that. So how are we going to optimize skin and soft tissue infection care? Mild and moderate ones can be managed with antibiotic alone. So there's not much of a problem. So you give any antibiotic which covers gram-positives, so that will be okay. But problem comes when you're managing severe end of the spectrum. And there's no universally accepted standardized approach in managing soft tissue infections. So how are we going to have a realistic strategy in managing skin and soft tissue infection? Most of the current approaches fail to address the complex diagnostic, clinical and therapeutic challenges of skin and soft tissue infection. So you take any guideline, so they have drawbacks. So they will only looking at microbiological dimension or the clinical dimension. I told you initially, so you have to think of both together. IDSA, that is Infectious Diseases Society of America guidelines are somewhat comprehensive approach empowering the healthcare personnel to manage the patients with skin and soft tissue optimally. So here is the summary of that. So here you can see soft tissue infections can be divided into two groups, non-purulent and purulent. So the non-purulent one, the necrotizing fasciitis, cellulitis and erysipelas, basically, so that will be toxin mediated, not due to organism but due to the production of toxin. So if it is severe, so as all surgeons mentioned, so your domain. And if it is mild, so you can manage with antibiotics. And then purulent infection, again, it has both the severe end and the mild end. Depending on the end of where the patient, your patient is, you can decide on the treatment, investigation and interpretation of microbiological investigations. And IDSA guidelines address both clinical dimension and microbial dimension adequately. So that is why it is the one that you can use effectively treat your patient. It has both arms. So how are we planning to have a generic management strategy for our patients coming with skin and soft tissue infection? First one, so you have to identify the syndrome. What syndrome you are managing with skin and soft tissue, whether it is erysipelas, cellulitis, impetigo, necrotizing fasciitis, myocarditis, myonecrosis, something. So then you have to guess the likely pathogen, which will be a difficult task. That is why I have marked it in red. So then you have to think of antibiotics, timing and the route. So how are you going to decide on that? First, you have to see whether there is sepsis. So sepsis is evidence of organ dysfunction due to infection. So if it is there, so you can, if it is not there, you can investigate. But if sepsis is there, it's a time critical, so you have to give antibiotics within 3 hours according to the Surviving Sepsis campaign, and if septic shock is there, it has to be within 1 hour. Treatment modality depends on the clinical presentation and the risk stratification of the patient. Soft tissue infection should manage before sepsis sets in. So that means there has to be a first responder's responsibility. The patient comes at the early stage to a general practitioner. So that first responder should be responsible for assessing the patient and reviving early, reviving the patient. So that is the most important thing. Otherwise, as Mihira said, the patients will come to surgeon late. Empiric therapy based on clinical dimension of the presentation. So when you are deciding the empiric therapy, it has to be based on the clinical dimension, the clinical spectrum that I have mentioned in my early slides. Targeting and discontinuation of antibiotics has to be based on the second dimension, that is the microbiological dimension. In conclusion, two-dimensional view of soft tissue infection highlight the crucial link between the microbes and the clinical outcome. Understanding both microbial and clinical aspects are key to effectively managing soft tissue infections of the extremities. And thank you very much.
Thank you very much, Dr. Mahen. Next topic will be tissue cover after soft tissue infection. This lecture will be done by Dr. Gayan Ekanayake, consultant plastic and reconstructive surgeon, North Colombo Teaching Hospital, out Kolkata.
Point. As plastic reconstructive surgeons, we get various sorts of tissue defects to cover from our general surgical, orthopedic and vascular friends due to different etiologies. Most of these are related to trauma followed by infection, resulting in various complex soft tissue defects requiring reconstruction. Some of these defects are led to heal with spontaneous healing with dressings, wound contraction and epithelialization. Some require active surgical intervention for the closure. Reconstruction simply means restoration of our structure, the body structure, and also the function. It's very important. Most of the time we forget the part, the function. Various reconstructive modalities are described in literature. I'll go through some of the simpler ones which we are performing commonly. What is best if we can achieve is primary tissue closure, which we can't achieve most of the time with these complex tissue defects. Primary healing heals with minimal amount of scarring. Sometimes we get patients after healing with deformities. So this is a result when you leave a wound to heal with secondary intention with scarring, which end up with wound contraction, development of contractions, unstable scars, and impairment of function. So this sort of wounds should have been managed differently, not with dressings. Smaller wounds with granulation tissue can be managed with dressings like this. Sometimes critical structures are exposed, but they are functionless, dead, like this tender Achilles. So in that case, we need to debride and let it heal for secondary secondary healing. In terms of reconstruction, skin grafting is a simpler way of reconstruction. It can be either full thickness or split thickness depending on the area and the requirement. For us to go for a skin graft, the first requirement is it should be a vascularized bed, irrespective of the size of the wound. After controlling of the infection or the colonization, then we can arrange for skin grafts. There are certain wounds which we are not able to manage with the simpler skin grafting. Wounds with exposed bone and fractures, exposed implants like in orthopedic fixations, joints and cartilage, vessels, nerves, tendons or tendon repair sites, and vital structures. So if your soft tissue defects results in this sort of exposure, then it's a mandatory thing that you need to cover them with some sort of reconstructive surgery. We call it flaps. They are tissue with its own blood supply. Many classifications are there. Depending on the requirement, we select what is best for the patient. So reconstruction infection, we have to think about the presence of dead tissue, ongoing tissue necrosis, presence of foreign material and infected implants or prostheses, and the presence of active infection or colonization. So these aspects has to be kept in mind and attended prior to the reconstruction. It's very important to have the correct blood supply. We cannot perform reconstructive surgery in a field where there's not adequate blood supply. So what are our principles? First thing is to excise or debride the wound thoroughly. So whatever the dead has to go. There's no reason for you to leave a dead tendon. It won't become alive again, or dead piece of bone. Thorough washout, identification of the infecting organism, and then get the treatment with the help of the Microbiological college. And then we always has to cover them with good blood supply, a vascularized tissue. It can be done as an immediate or a stage procedure. From here onwards, from head to toe, I'll show you some photographs, the clinical photographs. Rather than showing you a lot of words, I think photographs carry more message. So this is a necrotic piece of scalp resulting in exposed skull bone without periosteum. So this won't heal on its own. This is not a case for skin grafts. it has to be covered with vascularization. So in the case here, so we have covered with a scalp flap, local flap. This is a patient referred to as following necrotising fasciitis, exposed extensor tendons. These tendons cannot be left there for long period, they will die. Simpler reconstruction, so you can convert this wound to that wound with your debridement, and then a simpler reconstruction, groin flap, resulting in that sort of a functional hand. It's not only the cover, we have to think about the functional aspect of the patient. So cover with a flap and a skin graft for vascularized areas. So patient with significant soft tissue loss and infection. So loss of tendons, nerves, very complex one. Initial flap, soft tissue cover, followed by tendon and nerve reconstruction, regaining reasonably satisfied level of function for the hand. Necrotic infection in the dorsum of the hand, the moment you debride, you end up with exposed joints and tendons. Cannot be left for dressings, has to be covered with soft tissue or the flap. Sometimes infection can be of a smaller version. So this is a tendon repair site in zone 2 coming with infection. So this can be really debilitating for a patient even though the wound looks smaller. So immediate debridement, cover with a cross finger flap to get the finger healed. So another patient, zone 2 soft tissue loss following infection, had a flap. This is called the dorsal metacarpal artery perforated flap. This is the smallest perforated flap we would do commonly. And then for the loss of tendons, we need to undergo stage tendon reconstruction, resulting in this sort of function. Infected area on the dorsum of the hand, getting exposed of the joints and the tendons, covered with a posterior interosseous artery flap. So this is a common thing that we get. Patients following fractures and dislocation getting native treatment, ending up with large areas of tissue necrosis. So this patient had developed necrotising fasciitis and had wound care, ending up into this wound, and had a complex wrist injury. So my orthopedic colleague needed to reconstruct that, so he required soft tissue cover. So he underwent free flap for this purpose. Infection following sternal dehiscence, debride, and this covered with bilateral pectoralis major advancement flaps. Sternal osteomyelitis resulting in loss of the lower half of the sternum, reconstructed following debridement with a vertical rectus abdominis muscle flap. Sometimes malignancies can also present with infection. So this case, a fungating breast with pseudomonas, oncological resection, reconstruction with a muscle and a skin graft. Exposed mesh is removed, reconstruction with the ALT flap, a pedicle flap. Post-oncological radiotherapy leading to exposure of the mesh in the reconstructed area, infected, re-excision and then cover with the ALT flap. Soft tissue defects with infection. This is a VAC, vacuum assisted closure or negative pressure wound therapy. It's a temporizing technique, not a definitive one. Once the wound is improved, for a skin graft. Perennial sepsis, which has got poor control, resulting in a large defect after the pubic bone, reconstructed with a ALT flap. So this sort of wounds cannot be left for secondary healing. Fourniers gangrene is a fairly common thing that in our practice we get a lot of referrals from our general surgical colleagues for reconstruction of flap preserving the scrotum. Sometimes malignancies again can present like infected ulcers, excision and wide local excision and flap. Hidradenitis is a real cumbersome problem involving large areas of soft tissue. This is a bilateral buttock hidradenitis suppurativa. This is sort of a wide local excision and bilateral gluteal rotation flaps for the cover. They can develop acute exacerbations, as in this case, resulting in large areas of skin necrosis like necrotising fasciitis. Complex pilonidal sinuses covered with flap followed by excision. Another one of these. Exposed joints cannot be left open for longer, need cover with an appropriate flap. Large areas of bone exposure with fracture site exposure, this case followed by both gastrocnemius and soleus flaps. So long-term infection with a pseudoarthrosis and sinus formation, this had been there for 30 years. The orthopedic surgeon debrided and covered with a flap and then underwent bone reconstruction. Exposed ankle joints with a perforator flap. So large gastrilo 3C open fracture with Acinetobacter positive, debridement, bone defect, covered with soft tissue, handy bone work by our orthopedic team, resulting in a functional limb. Sometimes you need complex soft tissue reconstruction, including bone. Here it's a free fibula. This is a perforator flap for the leg. Infected wound in the leg with a fracture site, perforator flap. Tendo Achilles, exposed calcaneum. These are very common. You need tendon reconstruction, soft tissue cover, resulting in this. Very common. Large areas with granulation tissues can end up with grafting like this. Recurrent cellulitis with lymphedema, so debrided like Charles procedure with a skin graft. So in conclusion, so key is the debridement, excision, control of infection, timely reconstruction with soft tissue cover to restore the form and function. Thank you.
Thank you, Kolita. With that brings to the end of the four presentations. We have about 8 minutes left for questions. As you all can see, this condition, much spoken condition of surgical management of soft tissue infection poses a serious economic constraints to the healthcare delivery system, disability and death to the patients, and a severe emotional and psychological and financial impact to the family members. So I would like to invite the audience to come out with any questions or clarifications that they may wish to present to the expert panel.
Sir,
Below the fascia or?
so it
The
definitely
question is how deep should be the stab incision? Does it go below the fascia or stay above the fascia?
it definitely has to go below the fascia, sir. Yeah, till you see the deep fascia, that layer which I showed, the space between the dermis and the deep fascia,
Right.
it has to reach that space.
Yeah, but below the fascia then?
You mean?
Is there any danger of carrying the infection down?
No, sir.
the
We don't
muscle?
go unless, of course, we. I mean, I can't remember of a case which has gone beyond the deep fascia. There was one case which has gone into myonecrosis. That was apart from that, all the rest will stay above the fascia, above the deep fascia. Yeah.
Thank you. And the other one really, our chairperson also referred to it, to Dr. Mihira, the economic consequences. You know, you said, you discharge the patient and ask him to go for dressings and come regularly to the hospital. These poor people, they have to get a three-wheeler to go up and down. Each dressing, even in the private, some sort of, with the GPs, costs a lot of money. Then they are given a chit also to buy the antibiotics from outside. And these are very poor people who sort of can hardly afford 3 meals a day. When I was a trainee, my consultant was Professor Navaratne. He did 2 ward rounds every day. 2. Even after an operating list, he would come and do a ward round to make sure that he has control of all the patients in the ward. And he would never discharge a patient who needs further surgery or treatment. But that was an era gone by, you see. So that, have you given consideration to that when you are giving that advice to your patients?
Yes, sir. A very important factor, the arranging the post-op care, and during my practice, we make sure that we consider the economic problem in the patient. If they don't have a very good family support and economic burdens, better keep in the wards. Still we get adequate control and the proper plan, and and we, even if we discharge, we get the patient on Monday or a particular day, all the patient, and by the end of the ward round, the nurses prepare with the removing resin for surgeon to see all the patients. So by that way, I can assure that all my patients are in a proper progression towards the recovery. So by that way, patient go away. But what is happening in certain units, because of the bed pressure, to find the beds, free the beds, they discharge early, and sometimes in certain units, this discharging is without the knowledge of consultants. The SHOs and the HOs are doing, I suppose. So because certain patient, when I see, I can't think, why did this patient discharge? They do the debrine in the morning and transferred in the evening. Those kind of practice also there. So very pathetic, some people's attitude. They don't understand the cost involved, going with the 3-wheelers, and even the cost of the wound care products these days. They can't afford so many novel products. So the very much economic burden.
Can I ask a question? Now that point Professor Sharifdeen pointed out is very important, because HOs, they discharge and they review in 3 days or 4 days. So you have to think of that problem. My question from Mihira is, how do you control in diabetic foot infection spreads along the tendons, and where the outer tissue is good but the tendons are getting necrosed? How are you going to tackle that?
I expose along to the extent that I can drain all the infected tissue, and make sure whatever the necrosed tissue, I will remove until I see the fresh edges, and make sure the adequate drainage, and in the post-operative period the reducing the edema, elevation, and all severe patients, I initially start with a very good antibiotic, most probably the meropenem if it is available in the hospital. To the question you asked, so I split along go along the tendon sheath to the extent that I see the normal tendon area.
Why I asked this question is whether this maggot therapy, are you all not doing this?
I haven't personally used, but it's a commercial thing. May be beneficial. I have no experience, sir.
Anybody else?
Maggot therapy, sir?
Yes.
Yeah, maggot therapy is for de-sloughing locally. Sometimes it's useful, but there are limitations. The cost factor comes in a big way, and it's a process when the conventional methods don't work. If you have de-sloughing agents, mechanical and chemical de-sloughing agents, and sometimes when they don't work, we resort to this kind of techniques like maggot therapy and so on. It was once very popular, not much practice due to financial reasons and others. We have just about 2 minutes left. May I ask Mahen Kothalawala, with the permission, what do you feel about antibiotic usage in managing this diabetic food? Where we can see a lot of diabetic feet and other conditions are managed with all sorts of antibiotics, and there doesn't seem to be practice of using antibiotics rationally. You mentioned categorically that if there's septicemia, sepsis, then of course there's an indication for antibiotics. But if there's localized slough and all that, would it always be necessary for us to use systemic antibiotic, given the fact that these patients have peripheral arterial disease and so on? Can't we manage these wounds with effective antiseptics?
Yeah, so that's a very good question, and it has to be done with a conceptual framework. So you have to have some sort of a concept regarding wound infection continuum. So that is again a spectrum. So that is how the organisms interact with the wound. So there are contamination, colonization, critical colonization, local infection, and infection with sepsis. So you have to place the patient, where the patient comes to you, according to that spectrum and decide on the treatment. If there's a sepsis and septic shock, yes, broad spectrum antibiotic. But if you don't see that angry looking local infection and the patient doesn't have systemic symptoms, so that is a place where you can manage with local antiseptics. One is rotational, you can apply, and the aim of rotational antiseptic is to reduce the oxygen utilization by the organism. It is similar to offloading that you do with grafting. So the same thing can be achieved by reducing the microbial flora which scavenge on oxygen. And so that is a good thing. Another thing is about the investigation that you are doing. You are using the least important investigation, wound swab. Right.
Thank you very much, Mahesh. I think the time is over. The emphasis is that whenever you use antibiotics, better use it with the concurrence of the consultant microbiologist rather than haphazardly starting all sorts of sophisticated antibiotics. And very soon, I think, resistance develop and most of these wounds won't work or respond to any antibiotic that is available in the country. Thank you. With that remark, we'll call it the end of the session. And may I request my colleague, Dr. Duminda Disanayaka, to hand over the mementos to the resource persons.
Dr. Kosala Somaratne. Dr. Mihira Bandara. Dr. Mahen Kothalawala. Dr. Kolita Karunadas. Thank you, sirs. To thank our chairpersons for their invaluable contribution, I cordially invite Dr. Narendra Pinto to award them certificates of appreciation. Dr. Duminda Aryaratna. Dr. Duminda Disanayaka. Thank you, sir. Ladies and gentlemen, next up we have the third plenary of the session. This plenary addresses the very important, timely topic of new modalities in surgical training. I am honored to introduce our distinguished panel of chairpersons who will guide us through this vital discussion. Professor M.D. Lamavansa, Professor of Surgery and Consultant General and Pediatric Kidney Transplant Surgeon, Faculty of Medicine, University of Peradeniya. Professor Bhavanta Gamage, Professor in Surgery, Faculty of Medical Sciences, University of Sri Jayawardhanapura, and President, Sri Lanka Association of Minimal Access Surgery. Over to you, sirs.
Good morning to all of you. The third plenary of the day. May I introduce the speaker who needs no introduction to this audience. However, Professor Tan Arulampalam, he is an accomplished laparoscopic colorectal surgeon from United Kingdom. He was working as a consultant surgeon at Colchester General Hospital from 2003 to 2022, and he was the clinical director of the Assini Institute for Laparoscopic Surgery, one of the premier institutes in United Kingdom, and he was heavily involved in laparoscopic colorectal training as well. He has now diversified his expertise to human factors in surgical safety, which is a very important area that we need to address, and also medical research as well as healthcare process and delivery. He has trained many Sri Lankan surgeons and has been an ever-willing collaborator with College of Surgeons of Sri Lanka. Over to you, Tan.
Thank you very much, Bhavantha. Thank you, Professor Lamansa, and President and the Scientific Committee for inviting me. Yeah, I'm fine. Yeah, I'll do that. Thanks. Okay. So technology has now beaten me. I'm not sure what you've just done there. It's okay, let me sort it out. Okay. Good. I'll do it.